Uh, Hello, everyone. This is Dr. Ramesh Ayyala from Tulane School of Medicine, New Orleans, Louisiana. Today's topic is anatomy and pathophysiology of angle closure glaucoma. This lecture is presented by MediTred, a leader in online training and education. Remember, this is only part one of the lecture. There will be two more lectures following this to explain angle closure glaucoma, which is becoming a big topic in glaucoma world. I want you to look at these eyes carefully and remember this. Anytime you see a hyperope with deep sunken eyes, think of angle closure glaucoma. These are the eyes that are at the highest risk of developing angle closure glaucoma. Um, don't be in a rush. This could be a non-ophthalmic eye, which we will deal with a little later in the next two topics. Which non-ophthalmos, by definition, while we are at it, is an eye that is smaller than 19 millimeters. But in any case, most of these eyes that develop angle closure glaucoma are a little smaller than normal eyes, and as such, they can develop an attack of glaucoma. Now, let me explain to you why these eyes are at risk of developing angle closure glaucoma. The most important concept that I want you to take home today is relative pupillary block mechanism. What is relative pupillary block? It's the resistance to flow through the pupillary space due to close proximity of pupil to the anterior lens surface. When we say resistance to flow, this is the flow of the aqueous through the pupillary space from the posterior chamber into the anterior chamber due to the proximity of pupil to the anterior lens surface. Now, this resistance is worse in hyperopic eyes, and let's see the reason for that. I think I now have a nice schematic to explain this. Here is the schematic. As you can see in this schematic, this is the cornea, and here is your iris. Here is your natural lens. Here is the ciliary body. So you got aqueous being produced in this area and moving from the posterior chamber into the anterior chamber through this gap between the pupillary margin, i.e. the iris edge, and the underlying anterior capsule of the lens. So the closer this pupillary margin is to the anterior capsule of the lens, it's going to offer some degree of resistance. So this aqueous that's being produced in the posterior chamber has to overcome that resistance for it to go into the anterior chamber and from there exit out of the trabecular meshwork Schlemm's canal pathway. So this area is of high importance as far as patients with angle closure glaucoma is concerned. Normally, this resistance is less than 1 millimeter or so in most patients. However, in patients who are set up for angle closure glaucoma, this resistance is much higher. And so aqueous has to work its way through this gap to get into the anterior chamber. If there is a block in doing so, as is seen in this schematic here, the iris, the pupillary edge in this case is flat against the lens, underlying lens, and this typically happens or most likely to happen in a mid-dilated pupil, about 5 to 6 millimeters mid-dilated pupil. Then the aqueous cannot access the anterior chamber. As such, this aqueous that's accumulating in the posterior chamber here is going to balloon push the iris into a convex mode, and this in turn is going to block the angle structures and cause an acute attack of glaucoma. Even though the actual mechanics involved, I'm sure, is much more complex, simplistically speaking, I want you to understand this concept before we move forwards. So the factors that influence the relative pupillary block. Pupil size, I already mentioned that. Typically, the pupil has to be mid-dilated position, as you can see in this schematic again. At that mid-dilated situation, if the pupil is constricted, it is away from the edge of the lens, or from the anterior capsule of the lens. But when it's in the mid-dilated position, it's more likely to be in contact with the lens surface, or maximal contact is going to be occurring at that situation, mid-dilated pupil, 5 to 6 millimeters. Now again, if the pupil is, say, 10 millimeters dilated, as you can see in this example, if the edge of the pupil is in this area as opposed to in this area, then you can see the difference. The pupil edge is off the convex lens surface here, and as such, there is no way this will lead to a pupillary block mechanism. There's no resistance there at all. On the other hand, if the pupil is in the mid position, as in a constricted eye, then the resistance again is much less than in the mid-dilated pupil. So remember, it's the mid-dilated pupil that has the maximal relative pupillary block working against it because of increased contact between the iris and the underlying lens capsule. Either in extreme dilation or extreme constriction, the resistance is much less, and as such, the contact is much less between the pupillary margin and the lens capsule. As such, angle closure glaucoma is much less likely to occur. Lens size and position. Let's go back again. In this example, as you can see, in figure 2, the size of the lens is drawn to be bigger, and it's located a little bit more anterior compared to figure 1. And so typically, as we grow older, the lens increases in size, and in any situation that causes the bigger lens to be pushed forwards is going to increase the contact between the pupillary margin and the underlying lens situation. So this, as you can imagine, can happen if a middle-aged woman is in a dark room watching television, or because in a dark room, the pupil is likely to dilate to a mid-dilated position. And if the eye has a setup of narrow angle, smaller eyeball, shallow chambers, and a big lens, by the time you're 50, 60 years old, the lens is going to become thicker, then the chances of this particular eye to develop an acute attack of glaucoma is much higher. The other situation in the same setup is for them to accommodate, wherein they're going to do close-up work in the mid-dilate, in a semi-dark room. Aqueous humor, or the rate of aqueous humor formation. Now remember, the aqueous, it's the force acting on the posterior surface. Let's go back to this picture again. So the aqueous that is being formed by the ciliary processes occupying the posterior chamber, trying to get its way into the anterior chamber, is going to exert certain vector force on the posterior surface of the iris. And it's because of that that you see normally a slight convexity to the iris. Now, the iris convexity is not seen in every single patient. In myopes, you don't see that. In a young person, you have very little convexity of the iris. The iris is almost planar in those situations. But as we grow older, what's going to happen, as I mentioned previously, the resistance or the pupillary block mechanism is going to build up, and as such, the accumulation of the aqueous against the posterior surface of the iris is going to push the iris to become more convex. And that's the reason why you notice this convex iris. Every time you notice convex iris, we grade the convexity as grade 0, 1, 2, and 3. You can grade 3 to grade 4, meaning that the iris is bunched up almost against the cornea. You can see that the resistance is higher in the pupillary in the pupillary margin area. So one of the concepts that I want you to take home based on this aqueous humor formation and its its role in forming a convex iris is if you decrease the aqueous production, obviously the amount of fluid that is going to act as a vector force against the posterior surface of the iris is going to be decreased, so as to decrease the convexity of the iris, which in turn would mean that the angle structures will open up. So aqueous suppressants such as beta blockers or say Diamox can work at decreasing the convexity of the iris and opening up the angle structures by decreasing the amount of aqueous being produced. So this is the first line of treatment in patients with angle closure glaucoma. Use aqueous suppressants based on this mechanism that we just discussed. Rigidity or tension of the iris. What do we mean by that? The iris is a complex structure. It is not a simple brown or blue stuff that's allowing the light to go in and out of the eye. Apart from that, as we study more, in this particular lecture, I'm not going to concentrate too much on this other than to highlight the fact that the iris can act as a sponge. But the iris essentially and soak up the aqueous, and there is a role for the aqueous to go in and out of the iris too. And the thickness of the iris, the tension or the tautness of the iris have a role to play in angle closure glaucoma. Now, the iris, as you all know, is made up of the dilator and the circular muscle. And the constriction of the sphincter muscle is what causes meiosis, and the constriction of the dilator muscle is what causes the pupil to dilate, right? And so if you use pilocarpine in a patient, what's going to happen is that the pupil is going to constrict. Pilocarpine is going to cause meiosis by constriction of the sphincter muscle, and the patient is going to end up with a small pupil. When you have a small pupil, because of the use of pilocarpine, two things are going to happen. It's going to draw the pupillary margin away from the lens surface, and as such will allow aqueous to go through, as in figure 1. And 2, it's going to make the iris board-like and increase its tautness, and as such it's going to be less convex. So pilocarpine does two things in this setting. One, it causes meiosis, because of which the pupillary margin is lifted off the edge of the or the underlying lens capsule. 2, it's going to make the iris less convex, and as such will help opening up the angle structures or the pathway to the angle structures. So both ways, pilocarpine helps in breaking the attack in a patient with angle closure glaucoma. On the other hand, if you use a cycloplegic agent such as cyclogel and make the pupil big, like say 10 millimeters, and you bring the pupil to this position here, then also you will be able to break the attack of an angle closure glaucoma. And so there is a concept out there that instead of using pilocarpine in some of these situations, you may want to use cycloplegic agents to break the attack. But of course, it's going to work only if the cycloplegic agent successfully can dilate the pupil beyond the mid-dilated position, beyond 6 or 7 millimeters. And if it can successfully do so and make the pupil 8 or 9, 10 millimeters in diameter, then it's going to break the attack. In the middle of an acute attack situation, this is not unlikely to happen because of the ischemia that's already setting into the iris. And so that's one reason why we don't try using cycloplegic agents. But I hope you got the concept. Either way, you can break the attack. The other reason why we don't try not to dilate is one of the treatments or the treatment for angle closure glaucoma, as you know, is performing an iridotomy, which is to create a hole in the iris, so say somewhere here. So creating iridotomy is going to be much more difficult, in the presence of a dilated pupil as opposed to a pupil that is taut and constricted, such as is induced by pilocarpine. So there's other reason why we choose to use pilocarpine in these situations. And lastly, the potential forward position of the ciliary body, such as in plateau iris configuration, can also increase the relative pupillary block mechanism. As I just mentioned, we went through this mechanism. Pupil is key to understanding, or the size of the pupil, and the iris is key to understanding the mechanism as to why some patients develop angle closure glaucoma. In the mid-dilated pupil, maximum contact between the iris and the lens leads to angle closure. So the angle closure is initiated by normal physiologic dilation of the pupil, most often in dim light setting, emotional disturbance, shock, illness, or stress. Any of these situations can cause the pupil to become mid-dilated, and this increases the contact between the iris and the lens and set the stage for somebody to develop an attack of glaucoma. Now, there are some pharmacologic agents such as antihistamines, sedatives, muscle relaxants, and GI drugs, etc., that can cause the same thing, can initiate an attack in a susceptible eye by causing the pupil to dilate. So that's one reason why you see all these drugs have in their contraindications an eye that has narrow angles is should not take these medications. Let's go back to the role of pilocarpine one more time, even though I explained it already. Every time I discuss this with my residents, the next day I ask them questions on this. It's almost like goldfish memory. For some reason, they keep forgetting the role of pilocarpine and as to how, what is the mechanism of pilocarpine, as to why we use it. Pilocarpine, for your information, is the oldest glaucoma medication, described way back in 1850 or so. We'll have more on the actual mechanism of pilocarpine in the glaucoma medication lecture series. But from the point of view of the angle closure glaucoma pathophysiology, I'll deal with the mechanism restricted to this. The classic treatment in the setting of angle closure attacks is pilocarpine. This is age-old treatment that's been described. It reduces the relative pupillary block. We went through that in the previous slides via meiosis and decreased lens iris apposition. And I explained that to you again. Miotics prevent an attack by two mechanisms: pulling the iris away from the trabecular meshwork and making the iris taut, which cannot be pushed forwards, meaning less convexity towards the TM by posterior pressure. So remember these 2 points in a setting of angle closure. The reason why you use pilocarpine is, here, let me draw this again for your benefit so you understand this. Here is your cornea. Here is your convex iris. And you have your underlying lens, right? So this convex iris, if you make it to constrict, it's going to become bored like this, okay? With the pupil set about here. Consequently, what's happening, as you can see, is that it's becoming less convex and also allowing the edge of the pupil to move away from the lens, and as such allowing the aqueous to go from posterior chamber to the anterior chamber, and opening up the drainage pathways angle, the angle structures for the aqueous to get out. So the pulling the iris away from the TM by constriction of the pupil and making the iris taut and less convex are the two mechanisms by which it works in this setting. Now remember, this is not how it reduces the intraocular pressure in a patient with open angle glaucoma. The reason why it works in those patients to reduce the intraocular pressure, remember, is by its action on the longitudinal muscle fibers of the ciliary body, which is inserted into the scleral spur. And contraction of the longitudinal muscle fibers of the ciliary body results in tugging motion on the scleral spur and opening of the trabecular meshwork, consequently allowing more fluid to access the Schlem's canal pathway. That's how it reduces the intraocular pressure. Whereas in a patient with angle closure glaucoma, the reason why we use pilocarpine is for the two mechanisms that are listed here. I hope I made this very clear to you, and when I ask you this question next time, I hope you'll give me the right answer. And this is exactly what I said here. Constriction of the ciliary muscle is posterior traction of the TMY scleral spur, causes the opening of the trabecular meshwork and causing the IOP to be decreased. Okay, but on the other hand, it also does two other things. It relaxes. It can cause the anterior movement of the iris lens diaphragm, which can lead to a paradoxical angle closure in some of these patients. So you got to be really careful when you use this pilocarpine, especially the stronger version of pilocarpine, like 4% pilocarpine, in a patient with extreme narrow angles. You should be careful because if you use 4% pilocarpine in these patients, even 2%, I've seen this even with 1% pilocarpine, yeah, this can set the stage for a patient to develop an acute attack of glaucoma because of this anterior movement of the iris lens diaphragm, because of the relaxation of the zonules. And in the process, the lens will move forwards, causing a pupillary block mechanism to happen and causing the pressure to go up and the acute attack to set in. So you have to be careful about this paradoxical action of pilocarpine in some of these patients. So it's used to constrict the pupil and increase aqueous outflow through the major outflow pathways. Can induce acute angle closure glaucoma due to anterior movement of the iris lens diaphragm, axial lens thickening, and axial lens thickening and increased lens iris touch. So in the previous section, I mentioned as to how it prevents or it's used as a treatment in patients with angle closure glaucoma. Here, you have to understand there are exceptions to the rule for almost everything in life, and so is the case here with pilocarpine. You have to understand the other actions of pilocarpine for you to understand this. Here is the lens, here is the cornea, here is the iris. Let me see. And here is the pupil and the underlying lens. The lens is attached via zonules to the ciliary processes. So when you use pilocarpine, it's going to cause the pupil to become small, which we already discussed. So you'll end up with a smaller pupil. But the other thing that's going to happen with pilocarpine usage is that the zonules are relaxed. So the lens, instead of sitting here, is going to move forwards. Let me draw this diagram here for you to understand this. Here is the cornea, and the pupil in this situation, the iris in this situation is pushed forwards. Here is your constricted pupil because the underlying lens has moved forwards because of zonular relaxation. Okay, an important concept for you to understand that pilocarpine and other parasymptomatic agents cause zonular relaxation, causing the lens to move forwards. And if this movement is big enough, it can cause increased resistance by increasing the contact area between the iris and the underlying lens capsule, causing an angle closure glaucoma attack. On the other hand, the opposite to this is what happens in cycloplegic agents. It pushes the lens iris diaphragm posteriorly, breaking this attack, and that's one of the reasons why we use cycloplegic agents in patients with shallow chambers post surgery, and we'll have a discussion about this, especially in patients with malignant glaucoma. So here is a schematic of the same as to how pilocarpine can be a friend and in rare situations your enemy too. So pilocarpine in normal situation would make the iris taut and pull the pupil away from the lens capsule and open up less, make the iris less convex by and thereby allowing the aqueous to access the trabecular meshwork. Whereas in certain situations pilocarpine can cause the lens to ride anteriorly because of relaxation of the zonules, thereby increasing the contact between the pupillary margin iris and the underlying lens, preventing the aqueous from accessing the anterior chamber and making the entire situation worse for you. It doesn't happen in every single patient. It is rare, but something for you to remember and watch for. Like I said, in all these years, I've noted I had maybe two patients who exhibited this phenomena with pilocarpine to the point that they actually developed an acute attack of glaucoma. And I'll give you in the next lecture, I'll show you pictures of that particular patient who developed this paradoxical action of pilocarpine. Like I mentioned before, when you completely dilate the pupil, there is no pupillary block, and so cycloplegic agents can, theoretically speaking, unblock the pupillary block mechanism. Mid-dilated pupil, again I repeat, causes loosening of the iris, allows aqueous to push the periphery of the iris forwards more easily, causing the convex iris that you see. And physical bunching of the mid-dilated iris at its periphery may block the narrow angle, causing an acute attack of glaucoma to set up. Okay, so I hope you all by now are masters of this concept of relative pupillary block mechanism. Here is a schematic to explain the same. What's happening in the schematic, you have a mid-dilated pupil that's bound down to the underlying lens capsule. Aqueous that's coming out of the ciliary process now is accumulating in the posterior chamber. It's pushing against the iris, causing the iris to become more convex, and this convex iris against the angle structures is what is causing the obstruction, and consequently the patient develops a sudden attack of glaucoma. Let's go back to this very picture. Now that you understand, now I hope you understood the pathophysiology behind the angle closure glaucoma. Now it's more complex than this, but from your purposes, I think this is enough for this particular lecture. I'll go into more details as to how the mechanism of proposed iris structural changes will complicate this issue. But the reason why I want to take this opportunity right now to point out is the mechanism of treatment. You can conceive, based on the pathophysiology, you can conceive the treatment that works to break this attack of glaucoma. It's the aqueous production that's accumulating here, pushing the iris convex, right? And this convex iris is the one that's blocking the angle. Two important concepts for you to understand. So, and then of course the maximum pupillary margin iris contact in the mid-dilated situation. So what you want to do is to break the attack is decrease the amount of aqueous that's being produced. Use the aqueous suppressants. You want to get the aqueous back into the anterior chamber, and when you suppress the aqueous, by the way, it not only decreases the pressure, but also because there's less aqueous in the posterior chamber here, you will see that the convexity of the iris decreases to some degree. Two, you want to create a pathway for the fluid to access the anterior chamber, and the two ways to do that, to break the attachment between the lens and the pupillary margin here, and that's where pilocarpine comes in, by constricting the pupil inwards and lifting it off the underlying lens. And three, which is the classic treatment that we offer, which is to create a hole, a pathway in the iris itself, so the aqueous can access the anterior chamber directly, and that's the mechanism of iridotomy. Okay, so the understanding the pathophysiology is and the concepts behind it will help you design the treatment modalities for you to implement in a patient in the clinical situation. Okay, so let's go through some information about primary angle closure glaucoma that you need to know. 0.4% of the population may have critically narrow angles. In the Caucasian population, there is no sex difference, whereas in African American population, also there is no, in the Caucasian population, it's more likely to happen in females compared to males, whereas in African American population, there's no sex predilection. It's mostly genetic in nature. We do see quite a few patients in the area that are practiced here in New Orleans. The characteristics of the eye that are likely to develop an acute attack of glaucoma, smaller eyeballs, at least 1 millimeter shorter. These are usually hyperopes by about 1 diopter. Cornea slightly smaller than normal by 0.25 millimeter corneal diameter. The lens is more anteriorly positioned in this eyes. The chamber is shallow. Normal chamber is about 2.8 millimeters to 3 millimeters. These eyes that are prone to develop these attacks are about a millimeter smaller or shallower. So you're looking at 1.8 millimeter shallow chambers. The lens is thicker generally in this patient population, 5.09 millimeters versus 4.5 millimeters. We went through this, so I'm going to skip this slide. Relative pupillary block is the reason why you have the convex iris, even in a patient with occludable angles, and that can itself present as an acute attack of glaucoma. The small eye with the hyperopia, small cornea, well-developed ciliary body, and iris insertion into the anti-edge of the ciliary body, combined with anterior position of the lens and relative pupillary block. Now, if you have this mixture in a patient, and as that patient grows older, that lens becomes thicker, the AC becomes more shallow, pupil becomes smaller. This increases the relative pupillary block, setting the stage for this patient to develop an acute attack of glaucoma. So how do you make a diagnosis of this? This is a crude way, but you can spot these patients with shallow chambers. If you get more experienced, that I recommend you to do this. But as clinicians, as you see more and more of these eyes, you can shine a light on the eye, and you can tell if the chamber is shallow or not. Careful examination of the slit lamp, as is being shown here. You can see that the slit beam, you can see that the iris is convex, and the slit beam, the thickness of the slit beam against the cornea should be at least, the antechamber should be at least 1 cornea slit beam thickness or more in a normal eye. If it is less than that, you know that this chamber angle is shallow. But this again is a crude test. The definitive way of making a diagnosis of narrow angles is gonioscopy. Every single patient that walks into your clinic, you got to do a gonioscopy. No exceptions to this rule. Especially patients that you notice have shallow chambers, you have to do gonioscopy, and you got to document what you see. As is seen in this particular patient, there was a lecture that we posted several weeks ago on gonioscopy, and there is this wonderful website, gonioscopy.org, that I recommend highly. Every single ophthalmologist need to be familiar with gonioscopy. It's a skill that you need to master, and not only master, you got to examine the patients using the gonio lens to detect those patients that are at risk for angle closure attacks. After all, we are here to prevent disease process, and one way of doing that is actually to do gonioscopy to detect those patients likely to develop angle closure glaucoma. So in this example, you can see that the angle structures are occluded. You cannot see the angle structures clearly. Whereas if you compress the cornea with your gonio lens, you can see on dynamic gonioscopy, you can see that some of the structures are opening up here. important concept for you to understand. So in this particular eye, it's telling you that the angle is likely to be occluded, but has not developed synovial adhesions between the iris and the cornea. And so iris and the angle structures. And so maybe iridoplasty or iridotomy may be effective in relieving this occludable angle from going into chronic angle closure glaucoma or an acute attack of glaucoma state. This is the same patient, the left eye. This is a much more dramatic picture where you can see on dynamic gonioscopy the angle structures are opening up. And you can actually see a lot of pigmentation in the angle, indicating that this iris has been in contact with the angle for a period of time. These are the signs that you look for to advise the patient that they may benefit from prophylactic iridotomy or in combination with iridoplasty. Now, clinically, from the clinical point of view, these patients fall into several categories. Stage The most common that you see in the clinical setting is the occludable angle, patients with narrow angles or occludable angles. So what is an occludable angle? An angle width is less than 20 degrees on gonioscopy. Here is an example of a patient with narrow angles on OCT imaging system. You can see that the angle structure is narrow right here. Only a small percentage of these patients with occludable angles will actually develop an attack of glaucoma. Now, strictly speaking, if the angle is less than 10 degrees, we call that as occludable angle that deserves probably treatment. A relative pupillary block mechanism comes into play in these patients and will increase the intraocular pressure. Most common provocative test. So we decide based on certain things whether these patients deserve prophylactic laser treatment or not. And we'll discuss some of this in the later slides, but you may want to do a provocative test to decide if these patients are likely to develop an acute angle closure glaucoma. So the most common test that is used is a pharmacological pupillary dilation and prone dark test. And these, so you dilate the pupil, let's say with cyclogel, and actually I prefer to use something like phenylephrine that has less effect on the lens position. Cyclogel can theoretically push the lens back and consequently can make an angle open up when it normally will not. And so I like to use some weaker cycloplegic agents or actually mydriatic agent such as phenylephrine and see the patient before the pupil is completely dilated. In the mid, you need to catch the pupil in the mid dilated position. That's the idea. And if there is an increase in the intraocular pressure by 8 millimeters or so, then the test is considered to be positive. And also on gonioscopy at this stage, if the angle is more narrow than before, then the test is considered to be positive. And once you consider that the test is positive, at that stage, you may want to offer prophylactic treatment for this particular patient, such as an iridotomy. We'll discuss this a little later. So some of the provocative tests that you may want to be familiar with, the dark room test, meaning that the patient is locked up in a dark room for half an hour or so, and as you know, when you're in dark, the pupil dilates, and the mid-dilated pupil is likely to develop an angle closure glaucoma attack. So you want to check the intraocular pressure or do a gonioscopy, and then position the patient in the dark room and go back and examine the patient with minimal light in the room, with minimum slit lamp illumination to see if A, the pressure is increased, and B, the angle structures have changed in terms of the convexity of the iris, the shallowness of the chamber, and the visibility of the angle structures. If the answer is yes, then the test is positive. The answer is no, then the test is negative. Cyclogel 1% to dilate the pupil, and again, once the pupil is mid-dilated, you want to repeat intraocular pressure check and the gonioscopy. And if the pressure readings are greater than 8 millimeters from baseline, then the test is considered to be positive. So if you have this occludable angle and you do the provocative test, then a prophylactic treatment is indicated if you think that the patient is at risk of developing an acute angle closure glaucoma. So iridectomy is a treatment of choice if the patient is documented oppositional closure as peripheral anterior formation that's forming increased segmental trabecular meshwork pigmentation like I demonstrated in the previous example, history of previous angle closure, positive provocative test, or significant risk of angle closure. I.e., anterior chamber less than 2 millimeters less than 2 millimeter and in height, and strong family history of angle closure attacks. In all of these situations, prophylactic iridotomy is indicated. Beware of the drugs that can precipitate an attack because this is a frequently asked question, not only by the doctor, by your colleague doctors, internal medicine, ER doctors, etc., but also by the patient. Sympathomimetic or anticholinergic agents such as agents used in cold, treatment of cold, allergy, urology, antidepressants. And lastly, you got to be aware, even though we don't use it nowadays, the alpha receptor blockers such as the dapiprozole and thymoxamine, they reverse the pharmacologic dilation more rapidly than a placebo drug. Um, Now, some of these patients with occludable angles may develop intermittent angle closure glaucoma before they develop a full-blown attack. And so what's happening here is that in a given setup, such as in a semi-dark room, watching television in the evening in an eye that has a setup, as we discussed previously, as occludable angles, the pupil can dilate into a mid-dilated position, causing rapid increase in the intraocular pressure. Um, and once the pressure goes up rapidly to by 30 or 40 millimeters of mercury, the patient will develop mild corneal edema, and that can lead to blurred vision. And when they look at a light, they can see rainbow colors or halos, mild pain from elevated intraocular pressure, all these symptoms. And because of the headaches and the blurred vision, the patient may decide to go to bed at that point in time, and during sleep induced meiosis, the attack resolves spontaneously. So these cases, if you ask patients careful history, you can elicit this history of intermittent angle closures, and on clinical examination, i.e., gonioscopy, you can actually detect these patients' previous signs of angle closure, occludable angles with or without peripheral anterior formation, angle pigmentation. In the trabecular meshwork area that will give you a sign that these patients probably had intermittent attacks. That combined with the symptoms that I described before should lead you to strongly suspect intermittent angle closure. And if you do, and the patient is suffering with intermittent angle closure attacks, then of course you want to treat the patient with a peripheral iridotomy. And iridoplasty combination. And if the patient is of an age where there's underlying cataract, take the cataract out, and the patient will never have this problem ever again. Lens, as you realize, is a major culprit in a lot of these pathology, even though it may not be directly contributing to it. Indirectly, lens has a big role to play in almost 90% or greater than 90% of these patients. And so cataract extraction in itself could and is a very effective treatment form in a lot of this patient population, even though at this point in time there's not enough literature to suggest. But I guarantee you, as time goes on, I think a lot more publications will validate this concept. From your exam point of view, treatment of choice is laser iridotomy. Let's move on to acute angle closure glaucoma. And when the patient is having an acute attack of glaucoma, you classically see this mid-dilated pupil, as you notice in this particular patient. The anterior chamber is extremely shallow because of the convexity of the iris. The angle structures are not visible. The eye is hot, i.e. congested. Patient is in severe agony. Usually complains of headaches, and because of the acuteness or the suddenness of the pressure spike, this can manifest itself with nausea, vomiting, and there have been documented cases of patients being misdiagnosed in the emergency room as appendicitis, and where appendectomy has been performed in this patient population. So acute glaucoma is an emergency. It needs to be addressed immediately. So how do you know? What are the classic symptoms? The patient complains of pain, redness, decreased vision because of corneal edema, fixed mid-dilated pupil, shallow chambers, elevated intraocular pressure. Note this particular patient again, they always come back with this classic mid-dilated pupil, shallow chambers, and convex iris, and the eye is always hot. In this kind of cases, congested conjunctiva, corneal edema, and severe pain. I'll deal with the treatment a little bit later, but it's important for me to go through the various stages of this angle closure eyes. Some of these eyes can go on to develop chronic angle closure glaucoma. So we discussed occludable angles, we discussed intermittent angle closure, we discussed acute glaucoma. The end stage of all of this is chronic angle closure glaucoma, which essentially means there's a permanent closure of the angle structures because of adhesions between the peripheral iris and the angle structures, or peripheral anterior adhesions. It can follow previous attacks, i.e. intermittent angle closures, or it can follow an unresolved attack of acute angle closure glaucoma that can become chronic. Or more commonly, especially in the oriental population, it can occur gradually. It can skip. It can go straight from the occludable angle stage to the chronic angle closure glaucoma, skipping the intermittent angle or the acute angle closure attacks. And this is more commonly seen in the oriental population than in the Caucasian and the African American population. These patients present with persistent elevation of the intraocular pressure, and on gonioscopy you will see that the angle is closed. These chronic angle closure glaucoma patients behave and present like, in other words, like primary open angle glaucoma, and oftentimes is mistaken for that. So in this regards, this concept of creeping angle closure is described to this phenomena of gradual closure of the angle, usually seen in Asian population. Remember, it's the most common cause of blindness in certain countries such as China and India. Sorry. And on gonioscopy, you will see that the angle has peripheral anterior adhesions. The clinical course of this entity is similar to primary angle closure glaucoma and is oftentimes mistaken for it. So careful gonioscopy is the thing that distinguishes these chronic angle closure glaucoma patients from primary open angle glaucoma, as the treatment is somewhat different between the two. So once you have these patients with angle closure, the treatment that you need to offer could be prophylactic, as in a patient with occludable angles, or the fellow eye of an angle, fellow of a patient with acute attack of glaucoma in one eye. And let's go through the treatment for each one of these other steps. Prophylactic treatment is indicated for the fellow eye of a patient with an acute attack of glaucoma in one eye, or occludable those with occludable and narrow angles. Any eye with documented oppositional closure, peripheral sphenical adhesions, increased segmental pigmentation deserves this prophylactic treatment. Also, those patients that exhibit positive provocative test by 8 millimeters or more, shallow chambers, and strong family history. So the treatment that's proposed here is a peripheral iridotomy. So the way to do that is to constrict the pupil. Remember, excess light or pilocarpine can be used to constrict the pupil at the slit lamp. You want to use a drop of alphagan or iopane prior to prevent pressure spikes. You can use a condensing lens, such as the Abraham. And you want to choose an iris crypt, and you want to avoid blood vessels in the iris. And classic treatment is to place this under the upper lid. If here is the cornea, here is the pupil. You want to watch where the lid is falling. If the lid is like this, you want to place the hole somewhere here. In some of these, the worst thing that you can do is to place the iridotomy at the lid margin itself, because these patients will complain of double vision if you place it because of the prismatic action of the light rays passing through the tear meniscus. So either you place it far away at 12 o'clock under the cover of the lid, or it's perfectly okay for you to place the hole on the nasal or the temporal limbal areas. And you use the YAG laser, and we will have a separate lecture to discuss this, but essentially use the YAG laser to create this hole in the iris as a prophylactic treatment to prevent these patients from developing angle closure glaucoma in the future. There are some variations that you need to know. Some patients, some physicians pre-treat the iris area with argon laser. The idea there is to shrink the iris blood vessels or to thin the iris in a patient with thick iris, and especially in patients who are on blood thinners to prevent bleeding following the laser. You may want to pre-treat these patients with argon laser and then follow it up with the peripheral iridotomy in the middle of the pre-treated zone using the YAG laser. Complications of the YAG peripheral iridotomy include bleeding. Ocular pressure with contact lens can decrease this. Sometimes the bleeding is so severe as to fill the chamber and set the stage for an acute glaucoma from the blood itself, and that may need surgical decompression. Diplopia, like I mentioned, usually from tear meniscus prismatic effect. So try not to place the hole in the tear meniscus area. Localized damage to the lens capsule, cataract formation, which is a rare entity. And because of the pigment release, if it releases too much pigment, it can present itself as iritis and IOP spikes. These are all the complications from argon laser peripheral iridotomy. You need to know not only to recognize them should it happen in a patient, but also from your exam point of view. Here is a patient where iridotomy has been performed, and as you can see, the angle structure is nicely opened up following the iridotomy. The other entity that is gaining more popularity nowadays, underutilized but extremely valuable treatment modality, is the peripheral iridoplasty. It's a technique to flatten the peripheral iris or the convex iris and deepen the anterior chamber. Useful in occludable angles, acute angle closure glaucoma to break the attack, plateau iris, and non-ophthalmos. I cannot overemphasize the importance of this technique, iridoplasty. I don't know exactly who described this, but has been made more popular in the recent past by Bob Rich from New York. Great technique, always comes in handy to break an attack of glaucoma and also to treat these occludable angles. And we use argon laser burns to the peripheral iris using these settings to flatten the iris, and I'll show you some examples of this. So the laser spots of 200 to 500 micron spot size is applied to the iris in a 360-degree fashion, and as soon as the laser spot is applied, you will notice that the iris is pulled inwards, shrinks, pulled inwards, and as such moves away from the angle, and that's how it keeps the angle open. Here is an example of how this works. This is before treatment. As you apply the laser spot, you can see that the iris is pulled away from the angle structures, causing the angle to open up. So the iris becomes less convex, more taut, and angle structures open up. And that's how this works. Iridoplasty, here is a patient. You can notice that the angle here is shallow or occludable, and you can see following iridoplasty, it's peeled off away from the angle structures and opening, making the iris less convex and more taut. During the acute attack, classic treatment, as is described in your textbooks, you want to break the attack by giving IV medications such as Diamox or mannitol, oral medications, Diamox, isosorbide, or glycerol. These are all medications that reduce the vitreous humor. They lead to dehydration of the vitreous humor, which will drop the intraocular pressure. Topical medications after the initial treatment with IV medications or oral medications. Once the pressure starts dropping, then you can use the topical medications, 1 to 2% pilocarpine, beta blockers, alpha-GAN, or prostaglandin analogs. We'll talk a little bit about this a little later. Avoid strong myotics. Two things that you want to avoid: strong myotics and iopidine. The iopidine can increase or actually make the pupil dilate. It can cause pupillary dilation to get worse, and also can cause vascular constriction and cause the iris to become more atrophic. And so two things that you should avoid in this setup. One is stronger myotics that can worsen the pupillary block mechanism, as has been described previously, and iopidine. But any of these other drops that I described here, they can be used only after the pressure is initially reduced using these IV or oral medications. When the cornea, when the pressure in the eye is greater than 40 millimeters of mercury, it's unlikely, in the presence of corneal edema, it's unlikely that the topical medications will actually penetrate through that edematous cornea into the anterior chamber to have any effect. So the initial treatment is with IV or oral medications followed by topical drops. So the goal here is to clear the cornea or decrease the corneal edema by decreasing the intraocular pressure by a variety of means: IOP drugs, topical glycerine, or you can do paracentesis, which we'll discuss a little later. And once that's done, you want to perform the YAG peripheral iridotomy in one or more quadrants to establish communication between the posterior chamber and the anterior chamber. That, once established, will break the attack. And then continue with the oral Diamox, pilocarpine, and aqueous suppressants along with Pred Forte with gradual taper. Once that becomes quiet, you can assess what damage has happened and how else to handle these cases. If the patient does not respond to these measures, it may indicate chronic angle closure with peripheral synovial adhesions, and laser iridoplasty may be indicated in these cases. If there is no response to any of this, surgery is indicated, i.e. taking the patient into the operating room, performing a surgical iridectomy, plus or minus taking that cataract out. Now, the question whether you want to combine glaucoma surgery along with this cataract extraction depends upon the angle structures of the anatomy. If the angle is permanently closed, then you may want to consider it. If the angle is not, you may want to delay the glaucoma surgery drainage procedures to a later stage. to the fellow eye. Now, this is what the classic description in your textbook is, and this is what you're going to answer when asked in your boards and oral boards. The concepts of treatment of angle closure is rapidly changing, and that's the reason why I am making this statement. And I'll show you how I handle these patients. And the fellow eye, mandatory for you to do gonioscopy and a peripheral iridotomy. In a patient with chronic angle closure glaucoma, the preferred first step, according to the BCSE book, is iridectomy. And this is followed by iridoplasty and gonioscopy lysis, as is indicated. Then consider lens extraction with intraocular lens implantation. Based on how much damage has occurred already to the optic nerve, set a target pressure, and based on the target pressure, you may want to perform limbal filtration surgeries or a glaucoma drainage device implantation, whichever technique that you're familiar with. But these are the eyes that you have to worry about malignant glaucoma following the glaucoma filtration surgeries. So be aware of malignant glaucoma situation, and it's more likely to happen if you don't take the lens out. Um, we'll have a separate lecture again on this various treatment modalities. But for the purposes of this brief description, for the purposes of this lecture, know that the first step that the BCSE book describes is iridectomy followed by iridoplasty and gonioscopy lysis, and this followed by lens extraction in that order. So what do I do when I see a patient with occludable angles? I do a peripheral iridectomy plus or minus a laser peripheral iridoplasty. And if the patient has underlying cataracts, I would recommend taking that lens out. Once that cataract is taken out, these patients will never have have to worry about angle closure glaucoma ever again, unless they have plateau iris syndrome. So if a patient is old enough to have a cataract with occludable angles, treatment that I offer, do a little LPI, decrease the convexity of the iris so they don't develop an attack when you dilate the pupil on the table, take the cataract out, patient will do great. Now, some of these patients have such shallow chambers and so high positive vitreous pressure that it's difficult to enter the chamber. In this kind of patients, giving IV Diamox half an hour, 1 hour prior to the surgery will decompress the vitreous to some degree and make your surgery more accessible, make your surgery easier. And lastly, the last step that you need to understand, some of these cases, especially bordering on nanophthalmos or nanophthalmic eyes with very tight chamber, you may want to do a cord vitrectomy. You don't need to do extensive. I mean, all you need to do is a few seconds worth of cord vitrectomy that will deepen the chamber and that will allow you to complete your cataract surgery successfully. During an acute attack, what do I do? I've long given up putting the patients through this oral and IV medications and waiting and waiting and waiting in the clinic for hours on end before the attack resolves. As soon as I see a patient with acute angle closure glaucoma, the first thing that I do is talk to the patient. 2, take a consent. 3, betadine prep in the eye. Put a lid speculum, put the patient at the slit lamp. I do a 30 gauge, I use a 30 gauge needle and do a paracentesis. Once that's done, dramatically the corneal edema will decrease, the pressure goes down, the headaches go away, pain is gone, patient is happy, and then I do a laser iridoplasty and iridotomy, and I recommend taking that lens out, underlying lens out in this patient, so they never have to worry about this. So as soon as the eye becomes quiet, following the initial paracentesis and iridotomy and iridectomy, put the patient on tapering dose of steroids and glaucoma medications, and at the earliest convenience, bring the patient back to the operating room, take the cataract out, and that will solve the issue. Patients with chronic angle closure glaucoma, again, my recommendation, take the cataract out. Do not do a glaucoma procedure in these patients without tackling that underlying lens, because you're setting yourself up for a difficult postoperative course that can involve malignant glaucoma. Take that cataract out, perform gonioscopy lysis, and assess the angle. If the angle structures are visible, you may want to do the newer glaucoma canal-based surgical techniques such as an eye stent. But if the patient has advanced optic nerve damage, then you may want to do a trabeculectomy with mitomycin C, however, with tight sutures initially, and open the sutures, loosen the sutures in about a month or so to decrease the risk of, again, malignant glaucoma. Here's an example of how I do the paracentesis at the slit lamp. I will show these videos in a later talk, so watch for those. So from the point of view of your exams, and as I promised to my residents, I'm going to end these lectures with high yield material. Remember, the narrowest portion of the angle is superior portion. Physiologic dilation of the pupil is the factor most responsible for acute angle closure glaucoma. Pupillary block is the most frequent cause of angle closure. Pupillary block is maximal when pupil is in mid-dilated position 5 to 6 millimeters. Relative pupillary block is the underlying cause of 90% of primary angle closure glaucomas. The definitive treatment of acute angle closure attack is an iridectomy, laser or surgery. Aproclonidine can cause further pupillary dilation and iris ischemia and should be avoided in patients with acute attack. Fellow eye has 40 to 80% risk of acute attack in 5 to 10 years and should be treated with prophylactic peripheral iridectomy. Creeping angle closure is most common cause for chronic angle closure glaucoma. Angle closure in plateau iris is most commonly caused by anteriorly positioned ciliary processes. Okay, remember these points from your exams standpoint of view, and look out for more lectures on MediTred YouTube website. Look out for our CME and board review courses. As usual, I'm looking forward to your comments on ayala@meditred.com, or you can reach me at rayala@tulane.edu. Either way, I thank you for patiently listening to this lecture, and we'll meet next week with the part 2 of this angle closure glaucoma lecture series. Thank you.